Hello, good morning, good afternoon, good evening. I'm Dr. Kate, your radio. You're welcome to Classroom. Today, we'll be discussing local anesthetic agents, not the way you are used to learning it, okay? Something a bit different from what it's been. When you hear local anesthetic agent, as a doctor, you must have seen one or two local anesthetic agents before so that you won't cram it, all right? They have given it maybe before peripherally to block pain so that they can do a procedure, or they have given it intrathecal to do a regional anesthesia, or they have given it IV, as antiarrhythmic. That's lidocaine. You must have seen it being used. So you don't need to cram in local anesthetic agents. So what are local anesthetic agents? They are agents which, when given peripherally, reversibly block the conduction of nerve impulses. Reversibly, because after duration of action, the patient will begin to feel pain again and the blockade will be over, isn't it? That's why it's reversibly blocking the conduction of nerve impulses. Pain is an impulse. Pain as an impulse is conducted through a nerve to the brain and then back to where the painful stimulus is. And after the interpretation, the body will now know that it's a painful stimulus, and then you now have a withdrawal to pain, or cry or shout to pain. So what local anesthetic agent does is that it prevents this conduction of nerve impulses so that pain will not be felt, so that the stimuli of pain will not be felt. So that is local anesthetic agent. Then we come to mechanism of action of all local anesthetic agents. They are membrane stabilizer. You will not be wrong if you say that mechanism of action reversibly block the conduction of nerve impulses. It's true. That's what is in its definition and also in mechanism of action. But a little detail into its mechanism of action. Why are they membrane stabilizer? Are they able to stop the conduction of nerve impulses for the period that they are acting? Yes. You know what they do? The local anesthetic agent will bind to some form of protein at the membrane of the nerve. The nerve or the neuron, they have cell membrane. At these cell membranes, they have proteins there. And these proteins are, some of them are sodium pumps. Okay, they are sodium channels. What these proteins do, they have both alpha and beta subunits. So when local anesthetic, they are like gates too. They are like a door, all right? And you can describe them as door, as gate, or as a place that will allow access. That's what they do. So when local anesthetic agent binds to the alpha side of the subunit, alpha subunit of this protein, which is the sodium pump, okay? Sodium pump. When it binds to it, it will not prevent sodium from going through this channel. Sodium is supposed, which is an extracellular element, is supposed to go through this membrane, through that pump, through that channel into the intracellular, so that it can start up the process of depolarization. When there is no depolarization, there is no action potential. And it is action potential that will be the response of pain that is conducted through. After the action potential, the impulse is sent to the brain. The brain will now interpret it as pain and send it back to where it's been affected. Okay, so that there can be a withdrawal, a response, a dump, or as the case may be. So when local anesthetic agent binds to the subunits, the protein part, the protein now, which is the sodium channel at the membrane of the nerves, they will not stop these gates. They will not allow sodiums to go through. They will not be permeable to sodium anymore. And therefore, you can also refer to them as inhibition or inhibitors of depolarization. So local anesthetic agents inhibit depolarization and therefore preventing action potential and attendant transmission of nerve impulses, or you can refer to it as transmission of pain impulses. So if painful impulses are not transmitted through the nerves, they cannot be interpreted as pain. That's the mechanism of action. We have two classes of this local anesthetic agent. We have the amide and the esters. You can also refer to them as aminoamides or amino esters. So for the amide, I have a mnemonic for them: bread lamp. Bread as in BROEAD, bread lamp, LAMP. All right. Why the esters? The mnemonic for them is blood procalcitonin. The short form for procalcitonin is PCT, and the alphabet for blood is B. So it's BPCT, blood procalcitonin. So coming to amide, bread lamp. B in that bread is bupivacaine. Arrow is ropivacaine. E is etidocaine. A is articaine. D is dibucaine. Then you now cut to the lamp. L is levobupivacaine. Articaine is the A. M is the mepivacaine. Y, the P is the prilocaine. All right, you look at it. I'm going to type it out on the screen of this video so that you can look at it. Those are the amides. Then we now have the esters. When it comes to the esters, is blood PCT. That's B PCT. The P is 2, the C is 2, and T is 1. So the B now is benzocaine. The P is procaine. Another P is proparacaine. The 2C, we have cocaine and chloroprocaine. Cocaine and chloroprocaine. Then we now have T, tetracaine. So these are the esters and the amide with that pneumonia. So when you now talk about mechanism of action, I told you the mechanism of action is the same. Then you now talk about metabolism. All amides are metabolized in the liver except articaine. Articaine is metabolized just like the way esters are metabolized. They are metabolized in the plasma, okay, by plasma cholinesterase. Some we call it plasma pseudocholinesterase. Other we call it butyryl cholinesterase. In essence, what it is that all esters are metabolized in the plasma by plasma pseudocholinesterase. Anywhere you see it, they can call it esterases. They can call it butyryl cholinesterase. That is how all esters are metabolized. While all amides are metabolized in the liver and alkylation and hydrolysis in the liver by cytochrome P450. All right, all of them in the liver except articaine that is metabolized like the esters. That's the metabolism. Then you've talked about metabolism now. Then you now talk about the factors that will determine the onset of action of local anesthetic agents, specific properties of local anesthetic agents. Okay, when we talk about the properties of local anesthetic agent, we talk about 1, the protein binding of local anesthetic agent. The protein binding of local anesthetic agent will determine the duration of action of that local anesthetic agent. You don't need to cram it. When a drug is highly bound to protein, it will be released gradually. All right, you know that the unbind side of a drug is the active part of that drug. All right, so if a drug is poorly binded to protein, meaning that it has major part of its part in the serum or in the plasma, so that part that is in the plasma is the part that is going to be active. So for drugs that are highly binded to protein, they will be releasing over time, so it determines the duration of action. While when you talk about lipid solubility of local anesthetic agents, you don't need to cram it too. It determines the potency. A drug that is not well, that's not well soluble in lipid will not be able to permeate cells and tissues because it is needed. Lipid solubility is needed for permeation for that drug to get to its place of action where it can now start its action. So if it's not lipid soluble, it is not a potent drug. When it is lipid soluble, it's a potent local anesthetic agent. And then when you talk about the quick onset of action, the factor of lipid solubility is also in the quick onset of action, but it is in the form of fractions. I will let you understand. The pKa of local anesthetic agent will determine the quick onset of action of that drug, of the local anesthetic agent. You know what that pKa is? pKa is the pH at which the ionized part of a drug, that's the one that is water soluble, and the fraction of ionized part of a drug and the unionized drug, which is the lipid soluble, they are equal. The pH with which these two are equal is referred to as pKa, and this pKa determines the onset of action of local anesthetic agents. So I haven't talked about this. Then you now talk about the uses of local anesthetic agents. Local anesthetic agents, 1, they are used for local anesthesia, isn't it? That's why they are local anesthetic agents. They are used for regional anesthesia too. When you put in the tratica, for example, plain Marcaine injected into the subarachnoid space or epidural space for regional anesthesia. That's epidural anesthesia and spinal anesthesia. They are also used as antiarrhythmic drug like the lignocaine, which is a class 1B antiarrhythmic drug, isn't it? They are used for clinic procedure. That's the lignocaine. What it means is that office procedure. You can quickly do in the office, you can quickly do in the clinic, outpatient department procedure. You use local anesthetic agent. You can use local anesthetic agent for ophthalmology procedure, for dental procedure, and all other minor procedures in the form of local anesthetics, isn't it? These are the uses of local anesthetic agents. Local anesthetic agents are able to serve as antiarrhythmic drug because they are membrane stabilizer. That is what they also do in the cardiac muscle. They prevent depolarization, and by so doing, they stabilize the membrane, and so they treat arrhythmia. So there won't be action potentials being generated too frequently that will now result in tachyarrhythmia. That's how local anesthetic agents are used as antiarrhythmic drugs. So we're not talking about local anesthetic agents being given in combination with other drugs. For example, local anesthetic agents can be given with painful drugs like penicillin, such that these are drugs when given IM, they are very painful. So they give local anesthetic agents with such drugs so that it can tackle the pain that is associated with such IM injections. Okay? Then you now talk about adrenaline with local anesthetic agent. When you give adrenaline with local anesthetic agent, it's actually going to do for you 5 things. What are those things? 1, the adrenaline in the local anesthetic agent will cause vasoconstriction at that site you have infiltrated, and by so doing, decrease blood loss. All right, decrease blood loss for that surgical procedure. 1. 2, by vasoconstriction and decreasing blood loss, it will give improved blood feed. So meaning improved surgical feed, meaning that it will not be bloody and messy. So the surgeon is able to see what he's doing because the feed is clear. 3, it is able to prolong the duration of action of the local anesthetic agent at that site. Why? Because there's vasoconstriction, it will delay absorption of that drug. So that drug tends to stay a long time at that site of injection, by so doing prolonging the duration of action of that drug. And by this same mechanism of action of vasoconstriction and delay in absorption of the local anesthetic agent from that part, that is how it's able to also delay toxicity of drug. Because the drug is taken bit by bit into the systemic circulation, therefore, the tendency to go into toxicity is also delayed. It's also prevented, because as the drug is coming, it is being taken to where it's going to be metabolized. After its action is absorbed into the circulation, it's transported to the liver, and then it's broken down, depending on where it is, depending on what drug you have used. If it's local, if it's the esters, it's supposed to be broken down in the blood. But you know what? You know what I want to tell you? Esters are not readily available. I'll tell you that. Let me be done with the reasons why adrenaline will help in combination with local anesthetic agents at site of injection. So we have talked about 4 now: delaying the tendency to toxicity, prolonging duration of action, and then the last one, it will enable you diagnose inadvertent intravascular injection of local anesthetic agent. How will it do that? When you inadvertently inject local anesthetic agent into the circulation, it will increase the heart rate because it's adrenaline. So when you see the heart rate doubling, for example, before procedure, you took your patient's baseline, and the baseline is maybe 75, 78 beats per minute, and now your patient is doing 100 after injection of local anesthetic agent, you will now know that you have injected local anesthetic agent into the intravascular compartment. Those are the 5 things. All right, and now you talk about local anesthetic agent. We're going to be discussing its toxicity. Okay, we're going to be taking them one after the other, using the outline for pharmacology in the course of answering exam questions. As an anesthetist, as a resident going for exam, they can actually give you a drug, lignocaine, bupivacaine. They will say, write on this drug. So I'm going to give you the course outline. In case it's an oral, should I give you one chalk? One secret. If you pick a drug, local anesthetic agent, for example, lignocaine, bupivacaine, whatever it is, from the table of your examiner, and they ask you what class of drug is this, you know that at the bottle they did not put whether it's amide or ester. You know what I should tell you? It is amide. You know why it is amide? Esters are not readily available. The only ester we now have is cocaine, and we don't have cocaine on table. I'm very sure the examiner does not have access to cocaine, so cocaine cannot be there. The others are extinct because of their side effects and the allergic reactions that are associated with their use. For example, benzocaine is said to be implicated with methemoglobinemia. Okay, excess methemoglobinemia is associated with benzocaine, where you now have to inject methylene blue in trying to treat it. So for that reason, it's no longer for use, or it's no longer for clinical use. You can only talk about them for teaching, for research, and for exam purposes. Okay, so any local anesthetic agent you pick from the table of your examiner is an amide until proven otherwise. When you say it's an amide, you are 100% correct. And when they ask you about metabolism, it is the liver, except it is articaine. These are tricks with local anesthetic agents. I'm going to be talking about toxicity of local anesthetic agent, and I'm going to be describing local anesthetic agent one after the other. Before I go today, there's something I need to tell you, the outline for drug. I'm going to also type it too. One, when you are given a drug, the way to go about it, one, introduction. You must introduce that drug. For example, is lidocaine. I'll say lidocaine is one of the local anesthetic agents in anesthesia. It's readily available. It is cheap. Okay, and then you leave introduction alone. Readily available, cheap, and potent, and is used for short procedures and minor surgical procedures. Then you now come to physical property of that drug. We just talked about introduction. After introduction, you talk about physical property. Physical properties are those things that you see concerning drug. Look at the bottle, but if you cannot see the bottle, for example, if the bottle was not given to you, you are seeing lidocaine bottle in the theater. Okay, it's a multi-dose vial. You cannot use the drug at once, except you are using it to maintain anesthesia. Unlikely. If it's unlikely, then it's a multi-dose vial. It comes in a colorless fluid, in a clear fluid, in a clear bottle. And with adrenaline, it comes in a brown bottle. You know, those things that you see, they are the things you should be talking about. You talk about the concentration. It can come in 20%, it can come in 1%, depending on what it's being used for. Okay, and when it is 20%, meaning that the concentration is 200 milligrams per ml. When it is 10%, 100 milligrams per ml. You talk about the percentage, you talk about concentration. If there's expiring date, if you are giving a bottle, you talk about the expiring date of that bottle. If there's manufacturing date, if you are giving a bottle, you talk about manufacturing date. But if it is just an exam question, you don't need the expiring date and those other things that are not on the bottle. Then you talk about the chemical properties, where you talk about the chemical structures of the lidocaine. Don't forget that the lidocaine, they have the carboxyl group, the amide. Okay, so talk about the chemical structure of lidocaine. Then you now talk about the mechanism of action, which we talked about in general. I told you the mechanism of action is the same for all of them. Lidocaine, amide, metabolized in the liver by N-dealkylation hydrolysis by cytochrome P450. Don't worry, but just know that it happens in the liver. Then you now come to, after mechanism of action, you now come to pharmacokinetics. Pharmacokinetics is what the body does to the drug. All right, when you are talking about pharmacokinetics, you start from the dose of that drug. For example, we are doing lidocaine now. We talk about lidocaine with adrenaline and lidocaine without adrenaline. And for example, they gave you a bottle. You must also describe that in physical property, that is lidocaine with adrenaline. And you talk about the percentages and the concentration in each in that bottle. If there's no adrenaline, you also talk about the fact that it's plain lidocaine. It must be described in physical property. That's if it's the bottle that is given to you. So the dose, 3 milligrams per kg body weight if it's without adrenaline. If it's with adrenaline, 7 milligrams per kg body weight. You know why the dose is different? You know, with adrenaline, there's vasoconstriction, so the body will not absorb it fast. So the risk of toxicity is downplayed. But without adrenaline, it's 3 milligrams per kg body weight, because when you give it, the rate of absorption is fast. So if you give a too high dose, the risk of toxicity will be higher. They haven't talked about the dose of the drug. You don't talk about route of administration. For example, it's lidocaine you were giving. You say it can be given peripherally for local anesthesia. It can be given intravenously for as an anti-arrhythmia. Okay, and those days they used to use it for intrathecal injection, but because of its rapid onset action in the intrathecal and the attendant complications, it's no longer used for intrathecal injection for regional anesthesia. They haven't talked about route of administration. You don't talk about the distribution. Okay, then you don't talk about the metabolism. After following injection peripherally, you talk about it being absorbed into the circulation, and then it's carried through the circulation to the liver, and it's metabolized in the liver and excreted via the kidneys. It's metabolized and excreted via the kidneys. You're done with metabolism. ADME. So we used to say ADME, administration, distribution, metabolism, and excretion. ADME. That's what pharmacokinetics is all about. Then you now talk about pharmacodynamics. Pharmacodynamics, that drug course outline now. Pharmacodynamics is what the drug will do to the body, and that is taking system by system. For example, what the drug will do to the eye, will do to the brain, will do to the, you start from the head, that's how you go to the eye, to the brain, to the respiratory system, to the cardiovascular system, to the gastrointestinal tract or digestive system. You must have it laid out. Musculoskeletal system, you talk about what the drug will do to the system. That's the pharmacodynamics. I will talk about pharmacodynamics. You don't talk about indication. Indication is also clinical uses. Okay, what is it used for? You talk about what is used for. In the case of lidocaine, we talked about the uses. You put the uses down. After the clinical indication or uses, you don't talk about contraindication. Contraindication is where you should not use it. Then you not talk about the side effects of the drug. When you talk about the side effect of the drugs, then you not talk about the summary. That is the outline for drug. That's for pharmacology in case of exam. Hope you have learned something. We're going to be talking about toxicity of local anesthetic agent, and we are going to take all these agents one after the other in a course or in a lecture, such that if it comes in exam, it will be your friend. You don't have to crack your brain, to be very close, and the way you can remember them better. Okay, for today, what you need to learn is, one, we have the bread lamp, we have the broad procalcitonin, we have the admin. These are mnemonics that will help us remember all that we have to know about local anesthetic agents. Thank you for listening. Hope you learned something. Dr. Katie Yoredion will be here again. There's always something to learn. Anesthesia and intensive care made easy. Never going to be bored here. Have a great day. Bye.